it needs to be calibrated before it can be used to collect data.
That's right. Do you just trust the sticker though on the machine? What if the sticker says expired, but the site says no, he just didn't put a sticker?
I trust the sticker.
But what else is there? There's a log. Usually when these guys come to calibrate, they give a log. Equipment calibration log. Okay. So now, that means the drug is safe.
So far. Yeah.
And we would know from the newsletter how many have been randomized so far.
Right.
Is there a section in the reg binder for SUSAR or safety reports? Did you see?
There's a section, yeah.
Is it empty?
Yeah.
If you discover that.
You will call the person in question, you tell the PI, ask the PI what's going on, that you will need everything done as it goes.
Let's say PI is not there.
Then you speak to the appropriate person that you want to, you appreciate if they sign.
Speak to the coordinator.
As it goes.
Action item. Maybe, what if you notice this is a repeated trend, not just one time?
Then I have to speak with the project manager about it.
Yeah.
Then it becomes
Maybe,
a problem.
CS where it's bugs should be checked, right?
Yeah.
What if something's checked CS?
Then that could be a deviation.
No, if something's checked CS, it means clinically significant. So, what would happen? What should the site do in that case?
Because I remember we talked about this. You still talk to the PI about that and ask. Because like if something, I'm trying to remember the example he gave, someone's weight, like between the last visit, vitals, and the new, let's say it's heart rate, is he heart rate you use or what? It's let's say 75 and
That's an AE or not?
yeah.
But what about if this is if PI saw us and that they put clinically significant? What do you expect the site? What do you expect to see next in that source?
That it was addressed to see what's going on with the patient.
So if it's CS, you're gonna check: is this part of an existing medical history,
Okay.
or is this a new AE? And how do you check those two things?
If it's not part of the medical history, that's probably.
That's right. So in the source of each subject, there's an AE log, and there should be a medical history. Usually at screening, there's a medical history. So, and you better see a progress note from the doctor or the site, something. And usually, in the SOPs, will tell you what the site needs to do.
We did talk about.
What does the site say they should do in these cases? Usually, what? Redraw. Okay? Redraw. Now, what kind of visit is that? What's that visit called? If subject comes in. There you go. Hey, you guys know. Okay. That one you got. If they ask you that one, you got it. Unscheduled, you know it. That's right. And if it's still CS,
Then it's
and it's not part of med history,
Then it's an A.
then it's an AE. But how do you know?
That's based on
if
the
it's
PI's
an AE,
That's
discretion.
right. You don't want to turn into that monitor.
Let me, if it's an AE, or no, if it's medical history, I think it will rest with the PI.
That's right.
If it's
It's
AE,
always rests with the PI.
okay.
Okay, now some studies allow the PI to adjust the dose, even if it's blinded. There's higher and lower dose that they can adjust. So if you're seeing the CS, the PI thinks it might be related to the study drug, he could lower the dose. And if it's placebo, it's not going to do anything, but it's, that's the right procedure to do. If it still doesn't get better or it gets worse, then the PI has to make the right decision of what's going on with the patient.
So you wanna look for dosage.
PI prescribes like another medication for that condition. Then you gotta check, okay, then what do you check? If the PI, okay, CS, then they came in again, it's still CS, PI writes a prescription for, I can't think of any drug right now. Let's say it's a high cholesterol, so they assign a drug for cholesterol, okay? Is that okay?
Well, now you need to cross-check between condiments and
There you
medications.
go, ConMed, okay. What else will you check? Do you assume the PI knows the protocol and like the drug is okay? Is it an exclusionary prohibited med?
Right, so you wanna check the inclusion-exclusion criteria again.
And sometimes PIs forget, because they're thinking like clinicians, okay, well, this person's getting high cholesterol, I'm gonna write a prescription, that's it. But then, and then the coordinator says, okay, good, because they're not gonna argue with the PI. And then who's left to check if this is all okay?
Scary.
It's right. It's all on you guys. And gets a bad contraindication with the study drug.
Well, one, it's bad for patient safety, two, that patient might need to be pulled from the study.
Exactly, but whose fault is that?
It's
your
not
fault.
seeing the CRA.
Alright? Especially when you see meds, lab results, EKGs, and then you're seeing the medication changes. Always check, okay, is it exclusionary in the protocol? Like, there's a reason why they have exclusionary meds. Because they have a reason to believe it may react with the study drug and cause a serious condition to occur. Like fainting or even heart attack. Who knows? Right? So you gotta check. Because PI's busy, seeing like 50 patients a day, he's just treating like a doctor. Okay, coordinator is busy too, and they're like, okay, doctor took care of the patient, it's okay. And it's in the ConMed log and everything's good. Well, how do you know? You have to check. In my opinion, that's the most important. Another one that mistakes are made is on the randomization visit. If the inclusion-exclusion criteria is not met, but the site thinks it's met, and then the CRA doesn't really check, so they think it's met too, because they trust the PI, knows what they're doing. And then it turns out the patient should have never qualified. Maybe there was like a small line in the medical history that's exclusionary, and then something happens later, like a bad outcome. You write that, okay? Because those envelope, I've honestly never seen one, because I've only seen the outside. I haven't never opened one. But I think it's a code for the PI. Only the PI can open it, and it's a code for him or her to go on the IWRS and enter that code, and then it will tell, it will allow him to look at the subject and what drug they were assigned. So that's what it is, but if that's open, it's not a good thing because it should be sealed. So most likely, it's their IP log that goes in the rec binder. That has all the well, right now no subjects assigned, so it has all the IP in the inventory. And then whenever one gets assigned to a subject, it's written here date that it was assigned and then which subject. And also each subject should have their own subject IP log. And these things need to match up. And since this is a study with pills, you're also going to count the pills. Not now because they're all sealed, but if patients are in, you're going to count the pills. Monica's going to do IP accountability with you today. You're going to learn how you're actually going to count the pills from here. You're going to calculate, all right, you're going to learn today how many the patient should have returned, all right? And then you're going to see if that matches up with this, if it matches up with this, if it matches up with EDC, and if it's a protocol deviation or not. Right? So this takes some time too to do IP accountability. And a lot of CRAs don't have time to do that, so they just keep pushing it back. And then you get to the closeout visit and you have a mess because this has to all be accounted for at the closeout visit.
Thank you. In the subject what's it called?
Progress note?
Yeah, progress note, that they reached out to him, if either he brought it or not, or they should just, should be there.
Progress note? But what else though? Because there's another thing, let's say there's 3 attempts, okay? And subject's just not answering the phone.
Then you might,
What's the SOP about that?
what to do if you,
Most sites in their SOP have a certified mail, okay? You have to, after the 3 documented attempts, I know Sinead talk about this.
yeah,
Yeah? Certified mail. Well, I know Chris must have talked about this. Certified mail. It's documented. Okay? That's the last thing you can do. After that, the FDA says it's fine. You know, as long as this is documented, 3 attempts, 3 phone call documented, and then a certified letter, that's all you can do as a site. But if they're not doing expiration date of site,
I saw IRB, yeah.
when does
I think
site,
it's, Someone 21st, is the 21st of the month.
for what?
I remember the date is 21st of the
But for
month.
what? For the site or
For
the site renewal?
I did not see
I
that.
think it's the site.
That's
Sunday,
important. That's
21st.
important. What if it's expired, guys?
No, it's not expired. I know it's the 21st of the month.
Like the protocols have to get approved. Okay, the sites have the sites permission to do the research study is up for annual review. So you need to make sure that there's no IRB, expiration on the site renewal. And it takes a few days for the IRB to do it. So it needs to be IRB, when is the site expiration date for the IRB? It doesn't ask in the report. Site from using an expired lab kit in the future. How do you proactively make sure that that doesn't happen?
Because this kit expires in 2 months.
That's
And we still have this number of people coming in. So by next month, we need new kits so that this one can be removed from site. At least if I do that for every visitor to be able to stay on top. No,
And then if, the sites are supposed to be reordering when they're running out of kits. Some studies automatically send based on activity, but most still don't. And then they require the CRA to make sure proactively these things don't happen. So not only you have to deal with all that's going on and resolve preventing future things from occurring. All in a day's work, guys. Expired IP. What happens?
that's trouble.
Expired? Okay.
The moment they start this
Expiration dates. Not all have. You have to know the study.
Yeah.
Did you look?
You feel temperature.
Since the SIV.
I looked at the top page, instead of the entire. Since you had it.
Since the site received drug, or since the SIV, or if they received drug before the SIV, since that date, what's the temperature, min-max, okay, on each date? Were there any excursions? How do you know? And if there was an excursion, what do you do?
If there's an excursion, those products are no longer usable, right?
Maybe. So you have to ask.
Go with the SOP or the sponsor.
The site SOP is one, and then the sponsor, for sure, that would be an immediate thing to contact your lead and get an answer that day. Because if they want it quarantined, then they would want you to do it while you're on site. And now you're taking time with that instead of all this stuff. This way, the excursion is important. What about
The delegation law.
There you go. Yeah, see? You guys know. On delegation law, made CVs. If they're a clinician, they need a medical license. What else do they need? They need other things too. What else do they need? What else?
Should I just wrap them up with the certification?
Yeah, see in the report, you detailed, you have to put everything.
So that we.
Have one on your CV too. There you go. What else? Did you guys check the most training protocol version 1? And then not only that, but what date was that? Like, what date was the training, what version is the protocol that they trained on, and what date was that protocol approved. You need to have all those, okay? Initial and date every page,
Yeah.
and no missing signatures, no,
I didn't see that.
everything legible,
Yeah, because everything was typed.
okay.
I did not.
Ah, something,
Yeah.
okay, good. There you go, sure. Kristen, and then what is she gonna need? We're gonna need this,
Yeah.
we're gonna need this, because I think she's medical assistant, this. I don't think she needs this if she's not processing labs. And be added here, training log, right? That she was trained on the, they should still do it. They should be err on the side of caution.